All right. Well, thank you very much for this opportunity to speak today as part of this panel. It's an important topic and one that I've made a small bit of contribution by on what I'm going to talk about today. At the beginning of our gathering today, Secretary Greenlee remarked that the problem of cognitive impairment is and will be the problem that we have to address. I agree, and I'll give you two reasons why I think it is. One, I think, is a strategic and policy reason. Cognitive impairment in most post-industrial nations has now been recognized as a national problem. And the United States, as well as many other countries, have created plans to address cognitive impairment. They have commissions, but typically they frame it on a disease-based way, and of course that's as the problem of Alzheimer's disease. And Dr. Bernard brought this up, and it's been notable at our gathering today how little Alzheimer's disease has been mentioned. I understand why. It's only one of the many causes of cognitive impairment, and yet if you read NAPA's charge, the National Alzheimer's Prevention Act, it says very clearly that Alzheimer's disease is used as a useful term to capture the variety of causes of cognitive impairment in older adults. Parkinson's dementia, frontotemporal dementia, vascular disease are all recognized as causes, and yet Alzheimer's provides a convenient overarching label. Well, Alzheimer's disease manifests itself as losses in the ability to do activities of daily living, one of the first of which, of course, is the ability to manage your finances, which is, of course, one of the great setups for being a victim of elder abuse and exploitation. So I would appeal that I think the more that this mission could be linked to a disease-based mandate that right now has federal attention, I think the more progress will be made, and I think cognitive impairment is that entry point for essentially a strategic and political approach. The second reason why I think cognitive impairment is a highly valuable way to think about this problem is because it is a very sensitive and specific way to get to make sense of elder abuse, because it's a very real phenomena that does a lot of work to link the biological, the pathological, and the clinical with our ethics. And the ethical issue, of course, here is that we should respect the voluntary choice of the competent adult following adequate disclosure, or in a phrase, informed consent. And this idea of the ethic of informed consent, of course, is that it allows us to balance our competing commitments to respecting the autonomy of an older adult, or an adult, with our beneficent obligation to help people who can't help themselves. So those people who are able to make a voluntary choice and and are competent, following adequate disclosure, we will respect their choices. And those who can't, we will step in and help. Now, I recognize that that first bullet has probably caused some people to get rather bothered. As has already been evoked, the idea of competency is a very loaded term politically, ethically, and legally. I'm willing to relax that and simply say what we're talking about is having adequate capacity. I'm willing to relax that even more and say all I'm talking about is someone's just ability to make a decision. And we could actually strike the issue of competency and capacity, or set those words aside, and just say let's talk about fostering older adults' abilities to make decisions, make sure that we've adequately figured out that they can make a decision and help them to do that. And of course, sometimes they can't, and we'll have to deal with that when they can't. So what I'm getting at is kind of a semantic cure, which I realized as I was sitting here preparing this talk. I added these slides from Moliere's Bourgeois Gentleman. This is Monsieur Jourdain, our bourgeois gentleman, who's quite pretentious and seemingly wise, but actually quite silly, and his philosophy master, who's attempting to help him get through life. Monsieur Jourdain, I must confide in you. I'm in love with a great lady of quality, a lady of great quality, excuse me, and I wish that you would help me write something to her in a little note that I will let fall at her feet. Very well. That would be gallant, yes, without doubt. It is verse that you wish to write her, asked the philosophy master. No verse. Oh, do you want only prose? Monsieur Jourdain, no, I don't want either prose or verse. Philosophy master, it must be one or the other. Monsieur Jourdain, why? Well, because, sir, there is no other way to express oneself than with prose or with verse. Well, there is nothing but prose or verse? No, sir, everything that is not prose is verse, and everything that is not verse is prose. Monsieur Jourdain, and when one speaks, what is that then? Prose. What? When I say, Nicole, bring me my slippers and give me my nightcap, that's prose? Yes, sir. By my faith, for more than 40 years I've been speaking prose without knowing anything about it, and I am much obliged to you for having taught me that. By my faith, for more than 40 years, APS workers have been assessing capacity without knowing anything about it, and I'm much obliged for having taught them that. What I'm trying to say is, whether you like it or not, APS workers and those in the field are assessing decisional capacity. They're doing it now. Whether they're doing it well, whether they're doing it right, is another question. And so to say that they can't do it, to say that they shouldn't do it, is to say that they shouldn't speak either prose or verse. And so what will they say? So we just have to accept the fact that we're confronting aging brains that are failing. One of the first IADLs to go is the ability to make decisions. People who are dealing with these people have to decide if they can make their own decisions or not. We can call it something else if we're bothered by the politics of assessing competency, because only judges can do it in the United States of America, whereas in Ireland it looks like other people can do it. But that's the world we live in. So we need a semantic cure here. Okay, so let me give you a case to put some traction to the issues I'm talking about. I have an 85-year-old woman who's hospitalized for pneumonia, and she's now ready to be discharged. Her friend and her neighbor comes over, and she from a visit to her friend's apartment, and she's discovered 2 mispaid bills, a ledger with cash transfers to her daughter, and 2 full bottles of medications. The patient's daughter says that everything's okay, I'm looking after my mother fine, and the patient should go home to her apartment. The case manager asks you, I frame this as a physician, which I am, can we send her home? You ask the patient whether she'd like a nurse to come over to assist her with medicines and review how things are going at home, to which the patient replies, no, I don't like that compared to what I do. I don't like people coming over to my private place, and I don't want my daughter bothered. Okay, we're not going to work through this case, but I hope it evokes concerns of elder abuse and neglect, mistreatment, and raises your concern. It also raises your concern, well, can this patient make the very decision she's just made, which is, I don't need your help, everything's fine. And the answer is not in this case, but the answer could be figured out. Well, what is this case getting at? So let me deconstruct it with a 2-by-2 table here. I think many of the cases of elder abuse and neglect come down to this 2-by-2 table. On the top, we see the question of, is someone able to perform an IADL, an instrumental activity of daily living, managing their money, managing their medicines, preparing meals, the activities that get us out of our parents' basement as teenagers. And the question is, are they able to do it or not? And that's a clinical assessment done all the time by healthcare providers and others who, in a variety of services that interact with older adults, long-term care, et cetera. They're either able to do it or they're not. The second axis there is, are they able to decide how to manage an IADL impairment? So consider this case. Suppose as a result of rollerblading, which I don't do, I fall and break both my wrists severely and require massive amounts of traction and immobility of my hands. I would probably lose the ability to do several IADLs, like managing my money. But I would submit, as long as I don't suffer head injury from that fall, that I have the ability to solve that impairment in my ability to do my financial management. And I can delegate it to someone else and have them help me do it. Okay? So what I want to do is work through this 2-by-2 table created by, are you able to do your IADLs, and are you able to solve, if you had a problem, managing your IADLs? So in the corner created by the axis of yes and yes, I think that describes the classic independent living person. They can take care of their daily affairs, and if they had a problem doing them for whatever reason, they could solve that problem. That's just about everyone, I hope, in this room. Let's move off that diagonal to the off diagonals. Imagine the individual who can't perform an IADL. I already described it conceptually with a very classic, just physical impairment. But that person retains the ability to solve how to manage that. We would classify this as someone who is dependent in an IADL. I'm dependent on someone helping me manage my finances. But I retain the independence to solve that. So I'm okay, I'm managing in the world. The other off diagonal is I can do the IADL, but I don't know how to solve if I had a problem in it. I put not applicable there, but I pondered maybe someone with a long-standing developmental disability who's well-trained in doing a set of daily activities couldn't solve that. I'm not quite sure about that scenario, but it's a bit of an odd off diagonal. I think where the, if you will, the action is in this other quadrant here, which is someone who is dependent in assistance with IADLs, managing their money, managing their medications, like the case I presented you. But when presented solutions to manage those problems, can't solve that solution, can't work through that. These are two separate decisions You could be capable, I've argued, to do one but not the other. And they both are issues of capacity, but if you don't want to call it capacity, call it just fostering good decision making with older adults, but recognize they're two very separate decisions. Both require someone who's skilled to make the assessment and judgment about the ability to do it. And I would submit that we have arrived at this point in the 21st century to train people to do these assessments so that we can fairly and ethically decide whether someone's able to do an IADL and whether they're able to make a decision about how to manage an impairment in their IADL. More research is always needed, but also now is translation to get this skills into practice, and that's what I want to devote some of my remaining time to here. I think that we are poised to achieve clear and coherent and consistent communication about the concepts of capacity and competency. When I've studied the history of those concepts from about the 1960s on, much of the debates and fight have to do with people using the same words with different meanings or different meanings to apply to the same words. And I think now the field has arrived at a reasonable consilience of what we talk about when we talk about competency and what we talk about when we talk about capacity and how they're distinct and how we assess them. The theory and practice of capacity assessment has made substantial progress in arriving at a coherent set of concepts and practices that are legally and ethically acceptable. And so we can say with fairly good confidence that measures of overall cognition are not measures of capacity. They are related, of course. Someone who scores 2 standard deviations above the norm on an intense neuropsych battery, assessing multiple domains of cognition, probably the pretest probability that they retain the capacity to make most decisions is pretty darn high. And in contrast, someone who's 3 standard deviations below the norm on those measures probably does not retain capacity to make decisions. The extremes are easy. It's the middle where I think cognition at best points us in a direction of who's at risk for loss of capacity, but can't substitute for that. And yet, as has been pointed out by several speakers, many view an assessment of overall cognition as an assessment of capacity. Just give me the cognitive score and I'll tell you whether or not they have capacity. That just doesn't square anymore with theory and practice and the evidence. And so that's a solvable issue. It requires education and dissemination of that into those out in the field. Measures of cognition, as I say, are measures of the risk of the loss of capacity. And we have data, and I'm not going to show it to you, that clearly show that among certain well-characterized group, you can use good measures of overall cognition to predict the likelihood of someone not having ability to make certain decisions. But they can't substitute for that. Capacity is the continuum of the decision-making abilities, and I'll talk about what I mean by decision-making abilities in a minute. So that if you say that someone is competent to make a decision, you're saying that they have adequate capacity, and you're making it on the basis of a judgment. And it is a judgment, but it is a judgment informed by evidence. It is a judgment informed by evidence. And that evidence is someone who knows how to assess someone's decision-making ability for a particular decision. In the case of the case I gave you, that person's ability to manage her finances, you would assess that, and then you would make a judgment about that. And in the case of if you find an impairment, you would assess her ability to make the decision about solving that problem and make a judgment that the person can or can't make that decision. So what are the decision-making abilities? Broadly conceptualized, they are the ability to express a choice. I don't want my daughter to come over to my house. I have now expressed a choice, just right there for you. The ability to understand information. So in the case of, say, the one I just gave you, well, that ledger I have, that's my checkbook, and that's where I record whether I've spent money or gotten money in, so sort of understanding what a checkbook is. Appreciation, recognizing whether facts apply to you. Have you had any trouble managing your checkbook? Absolutely. My memory is horrible, and that thing takes me 4 hours to work with, and it's full of mistakes. Versus, no, I'm great at my checkbook, where you know there's evidence of impairment. And finally, reasoning, which is comparing one thing to the other or drawing consequences of a choice. So assessments of capacity based on assessing decisional abilities are used to make judgments of capacity, of competency. And as I've said, we've been speaking prose all along. We've been doing this all along. It's just a question of whether we're doing it right, using the right tools, or not. And so we could ignore it, but it's still going on. It's like the air we breathe. Good news is that instruments exist and new ones can be developed that structure how we decide whether someone can make a decision. These instruments focus on someone's ability, not their status, not the reasonableness of their decision or not their cognition, their ability. So we decide what abilities are relevant to say that someone has capacity, and then we assess those abilities and we make our judgment. Now, which abilities we pick is a choice. Do they have to understand, appreciate, and reason, or merely, as many courts say in some states, for certain kinds of decisions, only have to understand information? That's a choice. That's a decision we make as a society. But not status. Well, he's 85, he can't make the decision. Or he's got Alzheimer's, he can't make the decision. Or he's got schizophrenia, he can't make the decision. Or he doesn't have any of those problems, so he can make the decision. So not status, that no longer stands. And not reasonableness. In other words, well, it's the kind of decision I would have made, so they must have capacity. That's off the table. And as I've already talked about, cognition. Instruments that we use, structured interviews, questions to ask, even checklists or scores. However they're created, they specify the abilities we ought to care about. They allow us to demonstrate where there are impairments and where there are not impairments. They allow us to explain the clinical significance of overall cognitive impairment and neuropsychiatric impairment. So what is the clinical significance of having Alzheimer's disease and a mini-mental of 22? Well, one way to get at that is to look at its impairments on decisional capacity. And I can tell you they're pretty notable, but they're variable. They provide us a coherent language to talk about the Iadl, the instrumental activity of daily living, of decision making. In other words, we could just do a semantic cure around capacity and just say, oh, it's just another Iadl. It's the ability to make decisions. And indeed, the one Iadl that I think sets us up for that is financial management. I'll talk more about that in a minute. So, to return to my opening remark, the ability to assess decisional capacity essentially puts assessment into our ethics, gives some substance to this idea of respecting the choice of the competent or capable adult following adequate disclosure in a voluntary setting. By the way, I've not talked about voluntariness at all. It's a huge issue. It's very understudied, but it's come up constantly in the remarks today here. Okay, so let me talk about two kinds of ways of thinking about, or two genres or kinds of capacity. Financial capacity, which is described as the ability to manage money and financial assets in ways that meet a person's needs and which are consistent with his or her values and self-interests. Dan Marsden defines this in a wonderful, I'll give you the reference later, issue of Generations, and this is from a textbook where he also, I pulled this from. He's calling it financial capacity, but all along people have been assessing this just doing the Iadl of assessing someone's ability to manage their money. It's a multidimensional construct that consists of the four things I've listed out here. You'll have to recognize, obviously, that someone may be able to carry out some financial transactions, but not others. Okay? And it is, in a sense, an instrumental activity of daily living. And I've talked to Dan, and he has developed, let me back up. Dan has developed some a very thorough instrument for assessing decisional financial capacity. But he's also developed some more streamlined and focused instruments that allow it to be used in practice. And he's been working now with the state of Georgia on developing that and implementing that measure. And if I had to think of a vision, it would be that this kind of instrument should be standard of practice for an APS worker who has to go out and assess whether someone can manage their money. It should be standard of practice. So decisional capacity, as I'm presented it to you, one way to sort of think about it is the decision about how to manage an Iadl impairment. So I have found that you're having trouble, based on evidence I've accumulated about your finances and based on my assessment of your financial capacity, I found that you're having trouble managing your finances. Now we have to solve that. And the question, of course, has been pointed out is, do people want to accept the solutions that we can offer them? That is to say, are they capable also of assessing those solutions? And so my colleagues and I have developed an instrument called the Assessment for the Capacity for Everyday Decision Making, or the ACE. And what it is a measure of the ability to decide how to manage an Iadl impairment. So the study that we did to validate this instrument, we took a group of adults where an informant, a caregiver, typically a partner or adult child, mainly typically a daughter or daughter-in-law, told us about the person's functional impairments, documented. And then we asked the individuals who had cognitive impairment from very mild to moderate stage of dementia whether they understood that problem, whether they appreciated it, presented them options to manage it, and whether which option they wanted to pick and how they could reason through those options. And what we essentially found was that, a substantial number of older adults with cognitive impairment caused by Alzheimer's or its variants, from very mild to moderate severity, all of them could give you a choice. All of them could tell you what they would want or not want. And most of them could reason through that choice. They could give you sort of consequences. I don't want to bother my daughter. I don't want to think. But where you saw problems was substantial problems with understanding the information. They had a hard time explaining what their checkbook was for. They had a hard time explaining about how cooking worked, for example. But even more significant was deficits in appreciation. As carefully as we tried to ask it to them, as non-threatening as we tried to get them to look at the issue, they just didn't see that they were having problems with managing their money or their finances. A small portion did, about a third did. But the vast majority, about two-thirds, had a lot of trouble appreciating the presence of a functional impairment. And the only way we found that out is, of course, because we asked that. So one lesson I always take from many of the studies we've done of capacity in older adults is, if you give an older adult with cognitive impairment, and the paradigm I study is Alzheimer's disease, if you give them a decision, enrolling in a research trial, taking a medicine for Alzheimer's, solving a functional problem, if you give them that decision, pages of information, it's the most uncanny thing. They'll pull out just enough to tell you what they do or don't want to do. I'll join that clinical trial. And they'll give you reasons, like, well, research is a good thing, and Penn's doing it, and I think that, drugs are going to help. But then when you assess their understanding of that trial, that's where you start to see they just don't often understand the facts. And when you look at their appreciation, that's where you often see they have a lot of troubles applying those facts to their daily life. But it's only until you assess it that you pick it up. And it's only until you assess it that you find that there's a chunk of patients, depending on the severity of their cognitive impairment, who retain those abilities and can make the decision. But if you don't measure it, you don't know it. And so I've given you the references here. I get the slides. They're in the slides that I think are given out. And the first reference there is to the ACE, and we made it a shorter version of it called the SPACED, standing for Short Portable Assessment of Capacity for Everyday Decision Making. And it's interesting, we published that a couple of years ago. And I've got a lot of emails requesting copies of it. And most of the emails come from forensic psychologists and psychiatrists, or people in APS and discharge planning. Because the case I presented is just what they're dealing with. I've got someone with impairments. She's saying no, but I don't know if I should say, fine, competent adult, right to refuse, versus no, they can't make the decision. And so that's what we developed it for, to help structure that assessment. And then again, I mentioned that in the Journal of the American Society of Aging, the Generations, the journal, is the entire volume here, 36 from summer of last year, is devoted to financial capacity. And it's a very well done journal issue. All right, that's issues in sort of research. Now I want to just spend one slide, care, excuse me, and care. I want to spend one slide on research, and then I'll wrap it up. So the ethics of research that involves persons with disorders that may impair their decision-making capacity is reasonably well worked out. That is a very loaded phrase that I put up there, and reflects about 30 years of warfare amongst the research, regulatory, scientific, and bioethics world to finally arrive at what are we talking about and who's the group we're worried about. If we were gathered in the early 70s, it was research that involves individuals with institutionalized with mental disorders or something. I mean, it was just, the language was reflected evolving understandings of what is the issue. That's the issue, persons with disorders that may impair their decision-making capacity. There are well worked out guidelines now for under what kind of situations can those people be in what kind of research. And I'm not going to go through them. I think in the issue of elder abuse and neglect, there may be some concern over who can serve as the surrogate, if the research requires a surrogate. And that's a big if. And so, for example, in the case I presented, if you were going to do research on that older adult, I just raised the question of would the daughter be an appropriate surrogate in light of the information you have. I don't pretend to have that answer, but it ought to make you at least concerned. But again, not all research that involves older adults who have disorders that may impair their decision-making capacity requires a surrogate or surrogate consent. And again, the criteria are laid out very clearly. for when you would or would not want to consider the need to have a surrogate to help provide, enroll a person in research. So I put those 2 points out almost as more provocative points. I recognize the substance of my remarks were largely dedicated to the issues around care, which I do think we're poised right now to make real advances in the field to improve how we assess people's abilities to make decisions and to foster their decision making. Thanks.